So at the start we have to know the surgical anatomy of the segments that we are going to use in any time in the urinary tract. We will start with the stomach. As you see the stomach here, it's very important to understand the blood supply, the anatomy of the organ before you take it to incorporate it in any urinary tract. If we see here the stomach, the blood supply is coming, as you see, from the celiac. There is 3 blood supplies from the celiac. There is the hepatic, which will give to the short curvature blood supply, will give the gastroduodenal into the antrum and then to the duodenum, and will give also the right gastropubloic. And then here the short gastric will go into the fundus and part of the body, and then will give the short, the left gastroepibloic. And then the splenic, which will give also the lesser curvature. We see here the superior mesenteric will give supply to the small bowel, and then there will be the middle and right will come from the superior mesenteric, and the left will come from the inferior mesenteric artery. I just want to rush to catch because it's 100 هذا. So the stomach, the duodenum, ileum, appendix, and colon. These are the segments which we are going to use. The most frequently we are using is the colon and the ileum. We are not using anymore the duodenum, and nobody recommends to use the duodenum because of its characteristic of the mucosa and the layers of the ileum. It is loose membrane where the electrolyte will go easily outside this membrane, and there will be a lot of disturbance in the electrolytes after the incorporation of this segment of the duodenum. So we don't use this segment because the patients, they will have a lot of complication from electrolyte disturbance, which we are going to talk about later. The stomach, it is good, it is really less permeable, less mucosa than the small bowel, and also the metabolic disorder will be here is metabolic alkalosis. But it's far away from the area, and I need a lot of dissection to go down to the bladder. So the most frequent that we are using the ileum and colon. The ileal has some advantage, and the colon have some advantage. The colon has a wider diameter, the ileum has a smaller diameter, but the ileum has more mobility and flexibility than the colon. But either one of these two, they are comparable, and you can use it in incorporation with the urinary tract. We have to understand some of the metabolic changes that can happen from incorporation of a small intestine into or large intestine into the and expose it to the urine and incorporate it in the urinary tract. If we use the colon and if we use ileum and colon, the most frequent complication is metabolic acidosis, hyperchloremic. And in the investigations, they have found that the most frequent cofactor in producing this metabolic acidosis is the ammonia. Ammonium chloride from the urine will make the metabolic acidosis, as you see here. It will go in exchange. Instead of potassium with the hydrogen, there will be ammonia with the hydrogen. And it results in hyperchloremic metabolic acidosis. As I said, jejunum is a very loose membrane, and this is why we don't use it. It excretes chloride, it excretes sodium outside and water, and there will be a lot of loss of fluids, and at the end will lead into hypotension, into loss of, a lot of electrolyte disturbance. The stomach, it's good and can be used whenever there is difficulty to use the ileum. If this small bowel is irradiated, for example, or there is loss of large small bowel, large segment of small bowel, so you cannot use any more from this small bowel, or in cases of gross adhesions in the lower bowel or in the colon, then you may go for the gastric. Usually there is less adhesions than the small bowel and the these are only the two indications that you may use the gastric into the urinary tract. Nutrition also, it has many, that's how to treat the complication, I leave it, and that is a nutritional complication. If you use the ileocecal especially, will end with loss of vitamin B12 and pernicious anemia and other complications. Let us go to the bowel preparation. We know from start on that there is many types of bowel preparation. The advantage of the bowel preparation, it collapses the bowel, reduce the incidence of anastomotic leak, wound infection, and intraperitoneal abscess, and decrease the complication of contamination from bacteria. There is two types of bowel preparation: mechanical, it reduces the amount of feces; antibiotic, reduce the bacterial count; mechanical, the old-fashioned, where you put the patient on low residue diet, expose the patient, and or the old-fashioned also, the whole gut preparation, where you put NG tube and run ringer lactate and or normal saline replaced by 10% mannitol. This fluid and the mannitol may act as a bacterial nutrient, and they are not anymore in use. The disadvantage, it is not effective as the other methods in reducing wound infection and septic complication, and there is more reduction of aerobic flora. That's what we are using the LaFast solution daily. It is effective. And there was a lot of controversy to use mechanical bowel preparation with the antibacterial or not use it, but I found one of the very nice randomized comparative meta-analysis between 2009, where they have found there is no difference between using mechanical with non-mechanical or using only non-mechanical alone. So the mechanical, adding mechanical preparation of the bowel will not increase the complication of the outcome. Antibiotic, now we are using the third generation, cephalosporin. How to create an addition bag or addition sac to add it to the bowel. According to Laplace law, the sphere, the tension of the wall is proportional to the production of the radius and the pressure. So the more radius is the less tension and less pressure inside the sphere. And this is why you have to construct your continent pouch according to the shape. The shape have to be spherical in shape. That will reduce the pressure inside the bladder, the new bladder. It's not 100% this law will be applicable for the new bladder, but it's different because there will be splitting of the bowel in the antimesenteric border. We open it, so there is no more powerful peristaltic in this segment. It will lose the peristaltic, which will decrease the pressure activity. How much centimeter you have to use to create either ileocystoplasty or new bladder? There is many studies increasing the size of the segment that you are going to incorporate into the bladder is not going to help you. It may also create problems because the longer reservoir, it works as a floppy bag, and it's low intraabdominal pressure, but that will lead to prolonged micturition and will lead to higher residual. So your construction of the pouch have to go according to the studies. For example, Ghanem, Workery, and many others, they used only they started by using 60 centimeter segment of bowel, and then they changed to 40. They have found that increase of the bladder capacity from 150 to 450 and 500 within weeks in young patients and months in elderly. So 40 centimeter to create in adult a pouch, ileocystoplasty or new bladder is enough for augmentation or for creating new bladder in adult. Indication is in general, we use it whenever there is the bladder cannot be replaced, have to be replaced, or if you want to augment this bladder, like post-cystectomy, neurogenic bladder, congenital deformity, just general indications. Contraindications, there is major contraindication to urinary diversion, either due to bowel type specific, jejunum, as we said, we don't use it. Bowel injury by radiation should not be used, or continent-specific contraindication in elderly and spinal cord injury, or bowel abnormality, patient with poor renal function. Also, we don't use bowel because that may aggravate the problem and lead to renal failure. Patient with lack of motivation, most important, you have to tell the patient and train him before surgery, especially in neurogenic bladder, that they have to do CIC, clean intermittent catheterization. Without doing that, especially in neurogenic bladder, this bladder may perforate in any time. You have to follow the principles of intestinal anastomosis. You have to do adequate exposure, and don't limit your exposure. You have to have enough experience to go to deal with this bowel. You know where to release the bowel from its ligaments, from its peritoneal adhesions. You have to have a lot of exposure before going to be independent of anyone to do such major procedures. You have also to prevent local spillage of enteric content. So when you prepare a bowel, you have to irrigate this bowel with betadine. You have to clean it. So don't let any chance for a spillage of the content of the bowel in the bladder, which may end with peritonitis and disaster and failure of your surgery. Small tricks, but we have to do it. You have to oppose the cirrhosis to cirrhosis of the bowel, and you have to invert your anastomosis. Your suture not too tight that it leads to strangulation, and you have to realign the mesentery so you don't get any window to get hernia through. Surgical stable incorporated inside the urinary tract have to be avoided because that may lead to stone formation in the urinary tract. Factors affecting the breakdown of anastomosis: poor blood supply, local sepsis, irradiation, drains on intra-abdominal anastomosis. Bowel re-anastomosis, suture or stable. There is many controversies about using suture or stables, but mostly it's agreed upon that a stable provide better blood supply, reduce tissue manipulation, minimal edema, and uniform suture replacement. It's had a great ease and less time, and it's impaired the suture line. And the documented fistulas by comparing the suturing or doing stables, the leak fistula in stables is 2.8, and for a stable 3% for suture. So less incidence of fistulas after stabling. How to connect lateral the bowel? We use always the suturing, the stable. Sometimes we use there is 2 types or 3 types of the auto suturing. Either the circular, where we used it whenever we want to do end to end, or whenever we want to connect the bowel, the small bowel with the large bowel, re-anastomosis. We use the endo-GIA for re-anastomosing the segment later on. So we cut in between these 2 segments to make a wide open anastomosis. This is side to side. And then we close with TA60, as you see here. Types of diversion, there is many types of there is time, or shall I? Since 1950s, the evolution of urinary tract reconstruction has developed along 4 distinct pathways. So we divide the continent, the use of bowel into the segment, into non-continent cutaneous form of urinary diversion, such as ileal conduit. It is non-continent. Or continent cutaneous form. Continent, where we cannot use the urethra, so we create a pouch with an intercepted valve or different type of valves to make continent bladder mainly into the umbilicus. Non-orthotopic continent diversion, it is continent, but it is not orthotopic. Orthotopic means you have to bring it down into the bladder. It is non-orthotopic, and you bring it mostly into, depending on the anal canal, so you bring it into the colon. Or orthotopic diversion, you bring it to the native urethra. Non-continent diversion as ileal conduit, I think I have to pass it. So as I said, we use either the ileum, as you see here, that is the ileum, where it's going to one end of the ileum, the 2 ureters, and that one will go outside. Or we can use the colon. How to create the stoma? There is different ways of creating the stoma. As you see here, there's a stoma random skin. Or you can do nipple, where you do from the skin to the fascia, then back to the ileum, and back to the mucosa. So you invert it. That is the nipple stoma or rosebud stoma. Loop end, where especially loop end, where you take the ureter, especially we use it in the ureter, where you take part loop of the ureter and you incise it from here and you attach it to the skin. That is the loop stoma. If you do ileal conduit, you have to remember that there is complications, so you try to avoid it. Okay? There is a stoma, complications, stomal stenosis, so you have to try to avoid it by getting good stoma outside the skin, so you don't get stenosis. There is mebarastomal hernia, it may herniate, so you have to be careful in opening the sheath, so it will not, or the fascia, so it will not herniate. You don't leave a large hole that may create parastomal hernia. Stomal stenosis, ileal conduit, it is 20 to 24. colonic has less, because of the larger diameter, they have less conduit stomal stenosis. Ureterointestinal anastomosis. So when you do, we talked about the stoma in the conduit, how to do it from outside, but how to put the ureters into the bowel. So there is many different ways of doing the ureter into the bowel. First, you have to remember there is many difficulties that may lead to failure of your anastomosis, ureterointestinal anastomosis. If your ureter is lack of mobility, so you have to make it mobile. If there is an infection, you don't do the surgery, you have to treat this infection. If there is stones, you have to treat it. So whenever you found any of these things, either your indication for surgery started early and will lead into all these things. Do you have to do refluxing or not refluxing? There is a lot of controversy, but most of the authors saying it makes no difference, especially in urogenic bladder. If you want to augment this bladder, it will become low pressure reservoir and mostly there will be no reflux. The advantage, especially in the cancer cases of refluxing, that you can do follow-up by injecting contrast into the bladder and it will reflux to the ureter. It may diagnose of any residual tumor. The ureterointestinal anastomosis, the structure rate 3 to 5, ischemia, urine leak, radiation. Let me go quickly to this. That's how to do the ureterointestinal, either the lead bitter, where you incise the tinea and you do submucosal tunnel and you create your anastomosis. The good one that we do it in many procedure, like Mines procedure, where you re-implant in the colon your ureter behind the mucosa. And that's one of the advantage of using colon, where you can easily re-implant your ureter into submucosal, into the colon. Lead bitter, where you incise the tinea and you go behind the tinea between the serosa and the submucosa, and you bring your anastomosis into inside without opening the whole bowel. Then, that I'm going backward. Strickler, you go from the side, you make a small incision in the tinea, and you go to here and bring the ureter behind, in front of the serosa and behind the mucosa. Bagno, you open the tinea completely and then you make your subtunnels. Breakers that we used, which I saw you before, you just implant, re-anastomose the ureter into the segment of the bowel like an ileal conduit. Wallace, you anastomose this ureter, as you hear, split it, anastomose it, and use anastomosis to the end of the bowel segment. Split nipple, you can also use it as a help. You just you overfold your mucosa here over the serosa, and you implant your ureters outside, so that will help in preventing reflux. Tunneling a small bowel, that is a reduct, where you open the mucosa, but you don't overcover the mucosa, you just do anastomosis between the mucosa and the serosa of the ureter, and it will grow itself. I think I have to stop in this way because I saw Prof. The other part will take around another half an hour.
We have no time. Okay, thank you very much, Prof. Tayib. And we can allow just very few questions if you like. Any questions? Okay, while you think of one, I can make a comment. Prof. Tayib has illustrated so many types of diversion using large bowel, small bowel, and in the isolation of the small bowel segments, which can be a small segment used for augmentation ileocystoplasty, or a large segment used for reconstruction of new bladder. In order to expedite surgery, we use ligature nowadays to divide the mesentery to obtain the mesenteric segment. So do you use ligature in your...
Yes, I use it frequently, just because the trainees, they want to do stitches, so sometimes I just let them to do the mesenteric by stitching, okay? Ligate and cut in between.
Okay, thank you. Prof. Said, you have a question?
Yes, thank you, Prof, for this nice overview about new bladder. I have two questions. One of them in radiated bowel. If you choose to do diversions, which technique you're going to do and what type of procedure you will do? And the other questions, in doing the reconstruction of the ileo conduit or using the bowel, because there is a risk that you might happen, like in terms of forming stones in the new bladder, if there is any way of preventing that?
Okay. For your question in radiated bowel, usually, especially in gynae, most of the radiated bowel is the area close to the ileocecal, which is the first 6 feet of the ileum. So you try to avoid it. If you feel the wrist is healthy, the rest of the ileum is healthy, you can take this segment. The other area, which is low down in the pelvis, it where is the ligament of tratus. So you have to avoid these areas. But if more areas is radiated, as I told you, you have to go up to the stomach and take part of the stomach.
Okay.
And because for stones, most important, you have to avoid a stippler inside the bladder. CIC, you have to put the patient on CIC. A lot of fluids they have to take, patient will take. Most of the stones that we see, it's grow over the mucosa, over the secretions or mucus secretion of the intestine. So if there is a proper care of the continent pouch by doing CIC, washing this mucus, usually the mucus will decrease after 6 months. There will be atrophy of the mucosa. So in the first few months, you have to tell the patient there is no way. You have to clean, you have to be careful, or you will have a lot of problems.